Okay, so smoking cessation, we talked about smoking being a risk factor for a number of diseases. I think we all know that by now. But it is the leading cause of preventable mortality. And when surveyed, about 70% of smokers regularly say that they actually want to quit. So most people have some sort of a desire to stop smoking. It's just a matter of actually doing it. 40% would have tried to quit in the past year. 3 to 7% will be able to quit and remain abstinent for 1 year without the use of any type of aid. So that's cold turkey. You can see that's a pretty low response. And even with optimal treatment, only about 30% will actually make it through during their first time. So it's very difficult even with the pharmacologic efforts we have today. Best results involve some sort of like combined behavioral therapy plus pharmacotherapy. And we'll talk about some of the more vetted strategies that work a little better than some of the other ones. Smoking prevalence, you guys know I like naps and stats and stuff, so here you go. Who smokes the most in the U.S.? These people do. Who smokes the most around the world? I think the student, and this is probably old, so I don't know, it'd be interesting. Well, it's 2013, not that old, so it'd be interesting to see how this has changed. As smoking, I think, got stigmatized in the United States long before it did in Europe, or even just didn't take on as much. So I think we're seeing maybe that trend starting to shift, similar to how we're portraying it here. And I think a lot of it has to do with negative stigma. And I think there's good and bad to that. I don't necessarily like to stigmatize smokers because I don't think they're bad people, but I think that the disease the diseases linked to smoking are kind of significantly impacting our healthcare system. So it's a bit of a double-edged sword there. And an infographic, whatever. So what things are we talking about? Just in case you forgot, these things are causes of smoking. So some direct and some sort of indirect. So you have a number of vascular things. So one stroke, ischemic heart disease being the biggest killers that are probably directly, at least indirectly, or partially related to smoking. A lot of times things go hand in hand with other issues too, but there's definitely a correlation there. Cancers, this is a big one. Lung cancer, smoking being a major contributor for most lung cancer cases, and then COPD related issues too. There's some other things too there, but those are the big ones. So major diseases that we see on a regular basis. Big time dollars spent in these areas trying to prevent this. Not necessarily smoking, but trying to prevent like heart disease and COPD and with inhalers and manage those diseases as well. Okay, so what is nicotine? Nicotine is just one of 4,000 chemicals in cigarettes. It's not actually carcinogenic by itself, so all the other things in cigarettes are carcinogenic, or are possibly carcinogens, so I should say they all are, just probably aren't. But anyway, nicotine itself reaches the brain in about 10 seconds after inhalation, so it's very fast onset. And it works by hitting acetylcholine receptor subtypes within the central nervous system. So it's a fast-acting stimulant, and it has a number of downstream effects once it targets these specific acetylcholine receptors. So you get some releases of epinephrine and dopamine. Epinephrine is going to cause more of the peripheral effects people will feel, so increases in blood rate, heart rate, respiratory rate, similar to what you'd expect, kind of general stimulant effects, what you think about when you take a stimulant. And then dopamine effects. So dopamine is going to be an increased pleasurable response, which generally is thought to be the addictive component of nicotine. So when we talk about addiction and addiction medicine, the major theory is there's some sort of a link with dopamine, right? So something's increasing dopamine. All right. So, and again, just this next slide points it out a little bit more in depth on all the different effects nicotine can have. So remember, when we're talking about things that we talked about this way back in fall, but when nicotine is very broad spectrum and the number of things it affects. So with acetylcholine receptors, you get a lot of downstream effects within the central nervous system and throughout the periphery too. So dopamine, norepinephrine, we talked about those ones, but then you also get serotonin effects, endorphins, GABA, reduction of anxiety and tensions. There's a lot of different things that are at play here. So tolerance does develop to nicotine. You have to use more to get the same effect. And it's got about a half-life of 2.5 hours, so it doesn't last very long. And dopamine response is similar to heroin or opioid use. Interestingly enough, we'll talk about this in the next lecture a little bit more, but when you're looking at dopamine response, you're when you're looking at like nicotine or an opioid, you're looking at sort of indirect dopamine response. So the drugs themselves aren't necessarily causing an initial release of dopamine. They aren't necessarily binding to dopamine receptors right away. However, through downstream effects, there's some sort of a dopamine release that's happening. And it's different than a drug like cocaine or methamphetamine, which is going to be be more affected directly on some of those catecholamines like norepinephrine and dopamine. So anyway, it's got a biphasic mechanism, so you usually get sedative effects following stimulation with higher doses. And then initial stimulation can also be followed by a blockade of the receptors at really high doses, which can create a number of different effects. So, convulsions, respiratory failure may occur with extremely large doses, especially for somebody who's nicotine naive. So if a child gets a hold of an e-cig vial and drinks the whole thing, they could easily die. It's super potent and super toxic. Got to be very careful with these products. That's why it's a big question mark on the e-cigs and how potent they are, how easy they are to access, and how, we have something that's like bubblegum flavored or whatever they're flavoring these things as, how easily it could be for a kid to think it's candy or something. Not my kid, of course, but somebody else's kid. All right, side effects of nicotine. So we talked about some of these already, but just to think about what's happening in the body. So you have a number of different effects, specifically within the vascular system and the central nervous system, right? So you get changes in hemodynamics. You get increased clotting tendencies. You get variable central nervous system effects, gastrointestinal. So this is cholinergic, so you're going to get some cholinergic / anticholinergic related effects, which is a little bit interesting. Tend to be more, more on the cholinergic side, so like diarrhea, nausea, be things we might expect more with a direct cholinergic stimulator, but dry mouth might be more like due to the smoke inhalation, probably from directly inhaling through the mouth, not necessarily due to the cholinergic activity. And diseases, we've kind of covered this stuff already, so there's some more in depth here, in case you want to look at that. I'm not trying to make this a Dare commercial or anything like that, but I don't even know if Dare still exists. But the point of me putting this on here is that you can actually get pretty good effects from stopping smoking pretty instantly. So that's a nice tip if you're trying to get a patient to stop smoking, to say, hey, look, if you stop, you're going to feel like your blood pressure will normalize within 20 minutes of not having nicotine in your body. And then after that, 8 hours of not having a cigarette, carbon monoxide drops back to normal, and you might feel yourself like you breathe a little easier. So those things do take quite an effect pretty early on. I think, do I have another slide here? Maybe I don't. Maybe I do. But also your lungs do regenerate over time. I think that was later on that one. But over time, if you stop smoking, I think I showed you this during the COPD lecture, but your lungs will regenerate. You can't necessarily get back to where one of your peers would be as far as lung function, but you can get better than the average smoker in your same age group. So you can improve that as well. So the point is, it's never too late to quit. You always will get some benefit from stopping smoking. Unless you're unfortunately terminally ill from cancer or have metastatic lung cancer, that's probably not going to affect that, but at the same time, you could maybe have a little bit better quality of life. Okay, so there's been a number of studies looking at how do you get people off cigarettes, like what's the best strategy? And they found that actually small interventions actually had a really big impact. So simply just saying, hey, are you interested in smoking at this visit? Say no, move on. Those little reminders every time you see a patient, just asking them about it, can have actually a pretty big impact over time. And even if they seem resistant, that triggers them to think, well, maybe it's something I should. Maybe one day they'll suddenly say, yeah, you know what, let's give it a shot this time. Make sure they have access to adequate resources. So if somebody does want to quit, make sure that they have not only appropriate prescriptions if you want to try pharmacotherapy, but also have a support system. You should maybe consider following up with somebody. Setting a quit date is really important. So sit down with your patient, come up with a quit date, and follow up with them personally. So call them in a week and see how they're doing. It's a small time investment on your part that can make a big impact for the patient long term. Counseling, psychotherapy can definitely be a component of this, and it's been proven to be an effective component as well. And again, follow-up I think is really important for these patients. All right, so talking about the drugs, we have nicotine replacement therapy, which makes the most sense, I think. All we're doing is replacing nicotine without the health risks per se, so you don't have all the carcinogens, et cetera, going into the lungs. So nicotine itself, while it's not something that I'd recommend everybody just take on a daily basis, it's not necessarily all that harmful. Certainly you can get a number of different cardiovascular side effects with it. But the point is that we're trying to give people replacement without really causing that super high that they're getting from the initial puff of the cigarette. So we can give them more of a delayed release of nicotine, or we can give them a burst, but just not quite as high of a burst. So we have a number of products on the market. And they kind of fall into basically two categories. One is patches, which are long-acting, and the other ones are all short-acting variables. So this depends on how somebody's going to want to take the product. Somebody might have a preference for gum. Somebody might love the way the lozenges taste. The inhaler, even though you aren't actually inhaling it into your lungs, it's still absorbing buccally. People like the sensation of it. I don't know if that's the right word for it, but the fact that they're using it like a cigarette, so it's a similar feeling, familiar feeling. Nasal sprays are a little iffy, but you get the point. There's a number of different ways you can do this. For reference, cigarettes, one cigarette contains about 20 milligrams of nicotine, and you get about 1 to 2 milligrams per inhalation. So if you look at some of these different medications, like the 4 milligram is the high strength of gum. So we aren't even really, with one piece of gum, you aren't even coming in, it's like a fifth of a cigarette. So again, we're trying not to give them as much nicotine as they would give with a cigarette, but enough to reduce the craving. That's the point. It's very similar, I think, to opioid, like when we're talking about using methadone to manage opioid addiction. You want to give them that new receptor activity, you just don't want to give them that real burst of high activity. So it's a very similar process here. Okay, so how do we, I'm going to go into some of these products in a little more detail here, but I'm just generally talking about a strategy. One of the best proven methods for using nicotine replacement as a smoking cessation aid is to use long-acting plus short-acting, which makes sense. It's how we treat opioid addiction too. And you want to have that nicotine in the body regularly to help reduce cravings, especially early on. So somebody's stopping smoking right away, it's very difficult, of course, to go cold turkey. Even if you give them like as needed gum, maybe they're pounding, like 15 pieces of gum a day. That's still a lot of nicotine. How do we wean them off? And the way to do that, patches can help with that. So patches come in 3 different strengths. There's a 21, a 14, and a 7 milligram. And they actually say these are over-the-counter products. You don't need a prescription to buy them. But they say right on the box what to do. So if you smoke more than half a pack of cigarettes a day, you're going to start with the highest strength patch. I think I have this on another slide coming up. But the point is that you work your way down the patch, and then you give somebody something immediate release to help with those cravings. So they're still probably going to get cravings, even if a patch is providing 21 milligrams of nicotine per day. It's not very much when you think about how many cigarettes somebody might smoke. So still might need quite a few pieces of gum or lozenges or whatnot. All right, let's see. No FDA-approved products actually deliver nicotine as rapidly as a cigarette. Remember, this is by design, so we don't necessarily want that to happen. But know that patients, when they try these products, they aren't going to get that really quick buzz like they would from a cigarette. OTC products are the patch, lozenges, and gum. You can all get without a prescription. And you'll actually find that insurances, believe it or not, don't actually pay for these products in a lot of situations, which is kind of counterintuitive. You think they'd want their patients to stop smoking because it'd save them bundles of money down the road, but they kind of lump it all into OTC products, and OTC products they don't like to pay for in general. So it is what it is. Prescription only, the inhaler and the nasal spray need a prescription to purchase. You can use them in combination with other pharmacologic options. We'll talk about non-nicotine products, and you can use them in combination with like Wellbutrin. We'll talk about that in a second. And patients can try this without consulting their medical professional. So if they want to try it on their own, they can. But again, if somebody's interested in this, it's best to have some sort of guidance, because it does tell you how to do it on the pack. But if they're talking to a provider, talking to somebody about it, I think it's going to reinforce it better. Cardiovascular disease could be an issue. So if somebody has underlying high blood pressure that's really hard to control, nicotine replacement might not be the best for them. However, it could be because they're smoking, so it's kind of like, well, they're already consuming lots of nicotine on a daily basis, so how much worse could this be? And, you have to weigh the benefits and the risks with that.
Jen, do people ever use those over-the-counter products, like if they haven't ever smoked?
I don't know. It's a good question. I don't know if people have used nicotine in that way or not, if they try it. I worked with a pharmacist once that said she tried the gum just to see what it tastes like, and she's got a nasty headache, although non-smoker, so I don't know. That's my only experience with that. After she told me that, I decided never to go down that road myself. I don't know. Assuming you could get maybe a similar stimulant kick like caffeine, I just think people would rather drink coffee. Who knows? That's a good question. I haven't come across somebody who just uses like gum for that effect, though. Although, you could get to the point where you have somebody who quit smoking and then they continue to use the gum or whatever because they do like the effect of it from it. So not necessarily the same situation, but yeah. All right, so patches, again, 21 milligrams per day, highest dose. So if the patient uses more than 10 cigarettes, which is half a pack per day, they're going to be on that high strength patch. patch. So you can do more than one patch. If somebody who smokes like 2 packs a day, you could consider doing doubling up on that. It's not necessarily recommended per like the package. If you read it, it doesn't tell you to do that. But logically, you could do that. They're getting a ton of nicotine if they're smoking 2 packs a day, so you really can't hurt them by giving them 2 patches, and it might actually be beneficial. Problem is, it's going to take longer to taper them off. So you can always start with 1 patch, the high dose. You can add another if you need to. Most people who are like a pack-a-day smoker start with 1 patch, 6 weeks of therapy, and going to taper down, and then do 14 milligrams a day for 2 weeks, and then 7 milligrams for another 2 weeks. Oh, sorry, 6 weeks of therapy total, excuse me. So it's 21 milligrams, 2 weeks, 14 for 2 weeks, 7 for 2 weeks, and then you would be done with it. So that's the plan. Now, does that always work? You can tailor that as you need it. You know, you could always have them go longer in one of those intervals if you wanted to. There's nothing wrong with that. But the point is, eventually, you're getting them off that patch. Patches are kind of expensive. They aren't super, you know, they're not terrible, but they aren't cheap either. If somebody is less than 45 kilograms or they smoke less than cigarettes, you're just going to start at that 14 milligram per day and then do 2 weeks of that and then 2 weeks of the 7. Rotate sites. People tend to get some irritation. I don't know if it's the nicotine in the patches or it's just the adhesive that they use with patches in general, but people do tend to report irritation with this patch more so than other patches. So rotating the site daily can prevent irritation. And the one thing that nicotine has as a side effect, other than some of the stuff we talked about with smoking, is you get some CNS-related effects. So specifically, insomnia and vivid dreams are one of the big ones. And so some people will remove the patch at night, so they just wear it for 12 hours during the day, take it off at night, and so they can sleep. And in that case, you know, they're probably going to wake up with a pretty strong morning craving, but it might be better than having them not sleep at all. Just so they have something like to take in the morning, they can use a piece of gum or something like that right away. But that tends to work. It's not a bad strategy to try in people who have that insomnia effect from the nicotine patches. All right, gum. So 4 milligrams and 2 milligrams is what it comes in. So usually for somebody who's over 25 cigarettes a day, they recommend starting with the 4 milligram because it is, if you're chewing a lot of it a day, it can add up over time. So you want to be careful. 2 milligrams is going to be fine for most people. You try not to swallow the nicotine. So this isn't chewing gum like you would think of chewing like a piece of Trident. So you want to chew the gum and then you actually cheek it so that it can absorb buccally because it absorbs the oral mucous membrane. And then you would chew it again and then repeat it until you can't taste it anymore. Once the taste is gone, spit out the gum. Try not to swallow it as much as you can. It's going to happen a little bit. If you swallow a lot of it, you're going to end up with more nasty GI side effects. You're going to end up with more diarrhea, probably more nausea. So don't eat pieces of gum, don't chew pieces of gum and swallow them. Not a great idea. You can use the gum up to every 1 hour. Sometimes we'll have people on, you know, get a lot of craving, especially if they come into the hospital and they can't smoke. They might be on a lot of gum. Avoid acidic beverages beforehand. Coffee, juice, and pop can affect the oral absorption of the gum. And aggressive chewing and swallowing will not only cause decreased efficacy, but again, you're going to feel sick. Lozenges are very similar in concept. You cheek them, let them dissolve. Try not to swallow. There's, again, flavor and tastes. I think they come in like regular, which I have no idea what regular means for nicotine gums, like terrible tasting. I don't know. And they come in a mint and then like an orange or fruit flavor. Some of them are like that too. And then the inhaler. So the inhaler, the Nicotrol inhaler, is not an actual inhaler like we think of a traditional inhaler. So you puff it in like you normally would, but it's kind of got a viscous liquid in it, so it just stays in the mouth and absorbs buccally. So again, the point of the inhaler is really just for the fixation component of it, to get something that's stimulating that same mechanism of smoking. And I've talked to some of our cessation people at the hospital, and they actually say that by far and away, people like this the most out of all the products that they get in the hospital. And now these are people who aren't necessarily trying to quit smoking, they're just on this in the meantime because they can't smoke in the hospital. So who knows if this is a great sample size, but they would say that people generally like this the most. So we went on a shortage, we were out of this for a while, and I got tons of phone calls about it, and I'm very happy people. So anyway, it's an option. And it does have these little cartridges, and basically it comes with this plastic thing that's essentially a straw. It's nothing more than that. You just put the cartridge in it and you suck through it. That's all it is. It's not a very complicated mechanism here. Let's see. You can use up to 6 to 16 cartridges a day. I'm not sure how many milligrams are in a cartridge. I think 10 milligram per cartridge. Is that what it says in that thing? Something like that. So it's a little bit higher than like a piece of gum, but you can use it a little less frequently throughout the day too. And it probably doesn't absorb quite as well. It's a little bit indirect. Whereas the gum relies on you're cheeking it. Hopefully, it's getting more direct absorption with this spray. It's probably going in the back of your throat, probably swallowing a little bit of it. Anyway, the inhaler is a good option for people. It's not. Don't think about it as like a really rapid absorbing one. I don't think it's going into the lungs and absorbing like a cigarette. It's not. Nasal spray is the most rapid absorption we have through the nasal mucosa. You can use about 1 to 10 sprays an hour. However, people get really irritated nasal passages with this, so compliance is usually not. It's a big problem with this product just because people aren't going to tolerate it. So while it's good from that standpoint, it's rarely ever used. All right, so if you're wondering how many people quit smoking using any of these products, so there's some data. They did a Cochrane review on this in 2002. And the percentage of people that quit after one pass, you can see compared to placebo, a little bit higher across the board for all nicotine products. But the nasal spray actually had the best effect, so that was kind of interesting. Of course, it's not very well tolerated, so people don't use it all that much. But gum was pretty good. Unfortunately, there wasn't a combination of patch plus any short-acting, so we can't really compare that. But just know that nicotine alone does have a slight advantage over placebo. So there is that. And then Wellbutrin, bupropion is one of the pharmacologic agents. So you can kind of compare that here. Okay, so as far as other things go, we can consider kinetics and ethnicity as well. So I apologize, this is one of the only articles I could find with some of these comparators. I know white and other isn't the best comparison of ethnicities, but it is what I've got for you today, unfortunately. So anyway, you've got patches versus sprays. And if you're wondering about like how the patch absorbs, it was a little bit different. For some reason, Caucasian people tended to get a better abstinence rate than other ethnicities that they studied with the patch, but with the spray, the other ethnicities prefer that. So there's some interesting things there. Obese patients got a higher abstinence rate with the patch, lower with the patch, and non-obese got higher, which is probably what you'd expect due to absorption. Can be challenging with obese patients using transdermal delivery. And then depending on the nicotine dependence also, low dependent people responded better to the patch, high dependent people responded better to the spray. And this is something that could probably be expected just due to the spray's fast onset versus the patch's slower onset. So take that into consideration. Again, I think combining strategies is always going to be the best choice, but you might have patients with financial needs and they want to try quitting smoking, they just can't afford both. Tell me which one to try. These could be lead you down a certain path. Somebody's obese, maybe have them try gum or something fast-acting or an inhaler. Try the nasal spray, just might not work all that well for them. So just keep those things in mind when you're treating your patients. All right, Chantix. Varenicline is the newest medication for smoking cessation. It's a partial agonist on the nicotine acetylcholine receptor. And what you get is a partial stimulation, but you also get reduction of symptoms of nicotine withdrawal. It also blocks nicotine from any source you're going to consume it in. So this is one of the products, whereas with Wellbutrin, which we're going to talk about in a second, you can combine that with nicotine replacement. Chantix isn't going to do any good. If you try and use like a nicotine gum with Chantix, it's probably not going to have any effect. In fact, by design, it shouldn't. So Chantix binds really tight to those receptors, and it's going to take a lot of nicotine to knock that off of there. It's got a high affinity for those acetylcholine receptors. If you do enough, you could maybe get some effect. But the nice thing about Chantix is somebody can start it, they can be like, well, I'm going to have a cigarette that's part of my daily routine. They take a cigarette, they don't really get any effect from it. Huh, that was interesting. Maybe I don't need to smoke anymore. So it does have that effect that the other medications don't. It does have clinically superior quit rates compared to nicotine replacement therapy and bupropion. And the quit smoking 1 week after Chantix. So that's generally the strategy. I said you can keep smoking, but by 1 week into therapy, you should probably be just done. Again, it's not going to provide you with any benefit. The point is that you're done smoking. It's not like you want to quit smoking all the way through your Chantix therapy and then keep doing it. That makes no sense. So 24 weeks of treatment is about the standard course of Chantix total. So it is a bit of a long course compared to like 6 weeks of the patches, right? Neuropsychiatric effects are the biggest problem here. So depression, agitation, behavioral changes, and suicidal behavior have all been reported. However, smoking itself also causes all of these things too. So it's not like this is that new or it should be that new of a symptom. However, you might get those things that weren't present. Maybe if somebody's a casual smoker and tries it, never had those effects. They might get them with Chantix. So if somebody does have unstable psych history, probably not Chantix. It's a good bet, I would think, to avoid it generally. Cardiovascular disease, probably okay for the most part. Not a lot of hemodynamic side effects with Chantix. And nausea and vomiting, probably one of the biggest compliance issues for across the general population. So if you take it with a meal and a full glass of water, it reduces it dramatically. So that's just a good counseling tip. When this drug first came out, we saw a lot of people. I used to work retail when I was in school, and a lot of people who were taking this or starting this were coming back saying, I may be super sick, and we finally did some research and started telling people to take it with meals, and we saw a lot of good changes with that. So it seemed to decrease the nausea significantly. So comparison against varenicline, bupropion, and placebo. So there's no nicotine replacement in here, unfortunately. None of these studies are perfect. The smoking cessation studies, unfortunately, there's nothing that's like, let's look at Chantix plus combined nicotine therapy plus Wellbutrin and combined nicotine therapy and see which one's really better. Because Chantix doesn't want themselves to look bad, so they try and pad their study a little bit. So here we go with Chantix getting a pretty decent rate of abstinence right away. Does taper off over time, and with a year out, you do get a fair amount of drop, but you do get better clinical success rate than you do with these other options they compared it to. All right, then bupropion. So we talked about Wellbutrin as an antidepressant. Zyban is the brand name that they used for this when they branded it as a smoking cessation aid. It's the exact same medication. There's no difference. So with bupropion, the strategy would be to start 1 week prior to your quit date. You continue for another 7 to 12 weeks, and usually at least 12 weeks is recommended. You can continue it longer if you wanted to after that. Some people, when they quit smoking, they get rebound weight gain. The smoking has an appetite suppressant effect. It's a stimulant. So that's one thing that bupropion doesn't have as much of. Could be a benefit for some patients. Generic and less expensive than Chantix. So Chantix is brand name only. It's a newer med. Less side effects than Chantix. We talked about Wellbutrin being generally a very well-tolerated antidepressant. That goes for this indication as well. And you can combine it with nicotine replacement therapy. You could theoretically also combine it with Chantix. However, this isn't well studied, and I don't necessarily not recommending this to anyone, but it's something that certainly there's no pharmacologic reason why you couldn't do this. There's no drug interactions. They're totally different medications, so it might be worth a shot in some patients. All right, so to sum it up, you have your first step. I would say the best strategy for most high success rate, you're going to offer counseling plus either Chantix or combined nicotine replacement therapy. So consider going down one of those two roads. There's not really a better one. I think that Chantix is more convenient. So, if it were me, I might prefer to try taking a pill once a day at first, or maybe it's twice a day, I can't remember. But anyway, it's not, taking multiple doses of nicotine and applying patches every day. It's a little bit easier, I think, for the patient to comply with. However, nicotine replacement therapy, especially combined, is quite successful too. So there's no reason not to try that. Again, it's just sort of a personal gut feeling or clinical decision on your part. Of course, if somebody has psychiatric issues, go with the nicotine replacement therapy. Issues with cost. Somebody can't afford Chantix, their insurance doesn't pay for it, or they can't afford the combination nicotine replacement. Consider either starting with bupropion as a monotherapy, it's a cheap generic med, or try one single nicotine replacement, or do both. If they can afford their generic bupropion or their insurance pays for Wellbutrin, and they can afford nicotine gum on the side, that might be a good option too. So you can definitely mix and match with them there too. And then if we're looking at people who are being compliant with this, but they're having side effects, just try and switch it up. Try a different option. Try something you haven't done. Decrease your dose if you need to. And if you're not effective at all with anything, try combining therapies. So try combining what you haven't done. Maybe at this point, if somebody fails bupropion and nicotine replacement, maybe you can get a prior authorization to get that Chantix paid for. So there's other options you can do. But really, there's not a lot for smoking cessation. There's really just those three things: nicotine, bupropion, and Chantix. You just kind of mix and match. Try one that works. It's not uncommon for patients to fail. As I showed you, 40% down to like 20% or maybe 30% within a year for optimal therapy with counseling plus one of these options. It's a lot of patients who are going to come back in after a relapse and need to try it So the question is, what do you do somebody is in that situation? Well, did it work for them? Did they get off some cigarettes for a while? Do the exact same thing. Try it again if they're willing to go through it again. If it didn't work at all, try something else. Yeah.
How does the Wellbutrin actually work? Is it like the Chantix can use this?
No, so Wellbutrin is basically a dopamine reuptake inhibitor. So you get an increased dopamine concentrations in certain parts of the brain. So it's thought that it just helps with that pleasurable fix that smoking is causing. So, yeah. It's kind of a totally different mechanism. All right, withdrawing from nicotine, so stopping cold turkey, anxiety, depression, restlessness, headaches, increased appetite, difficulty concentrating. It's really uncomfortable for people. It's not going to kill them. Bottom line. Special populations. What about adolescents who are smoking and want to stop? You could harp on them, be like, you're gonna, show them a picture of an older person and say, you're gonna be even more wrinkled or whatever. I don't know. You could try and get on them because they're still young. They've got plenty of time for their body to regenerate, their lungs to heal up. So those types of things I think can be good selling points to teenagers or young people in general. Nicotine replacement plus counseling has been shown as a proven method that works well for adolescent population. Varenicline and bupropion. Not that you can't use them, however, they aren't studied. They're only studied really in adults, so we don't know for sure. But likely it would be fine to try as well. Pregnant women have multiple opportunities via various interventions, and you can educate them on lots of risks. It's kind of similar to your adolescent population. There's a number of things that apply specifically to pregnant women that you could guilt trip them a little bit on. The most benefit is in the first trimester. So that's when the highest risk is for smoking during pregnancy. After that, it's still a risk, but it's less of a risk. So that's where you really want to get the patient to stop if possible. So if somebody's like, I can stop for a little bit, but I gotta I gotta get back on cigarettes at some point. Maybe if they can agree to the first trimester, you can go from there. Baby steps is always good. Nicotine replacement therapy and Wellbutrin are thought to be relatively safe in pregnancy, better than smoking. So if you can get them to use that, that'd be fine too. Chantix is not well studied in pregnancy. And e-cigarettes. So just sort of a caveat here, nothing really to talk about. They aren't FDA approved or regulated. So what an e-cigarette is, it's a liquid that's aerosolized via some sort of a heating system within the e-cigarette itself. There is some data actually looking at using e-cigarettes for cessation, and they haven't shown any difference between an e-cigarette cessation versus just standard nicotine replacement therapy. So the problem with e-cigarettes is who knows what's in them and how much nicotine they have. So people can get really variable amounts of, and I don't know how these companies are distributing them, if they distribute like a concentrate and then these shops are mixing them themselves. I have no idea how this works. I think it's all behind closed doors and all unregulated and all a little bit scary to me personally. But the products that are in the liquid are like propylene glycol and other types of propellants, not known to cause cancer and not thought to be carcinogenic. But again, we haven't had e-cigarettes around long enough to know for sure. So who knows if you put that into your lungs for 30 years if you're going to get other issues. So that's just a question mark. Thought generally to be safer. The question might come up, are e-cigarettes better than regular cigarettes? I can't answer that, maybe, but there's not enough evidence to say yes or no at this point. A lot of places that ban smoking, like restaurants or hospitals, we ban e-cigarettes too, so they consider them one and the same, more or less. What else is there? The social stigma, I think, that's been associated with cigarettes for such a long time has been reversed somewhat with e-cigarettes. I think that's one of the big public health concerns is that if we allow people to use e-cigarettes in public places and say they're safe and say they're fine, that might make smoking also to be considered safe and fine. Those two don't go hand in hand. That's some of the logic behind that as well. Not necessarily that we're for sure that they aren't safe, we're for sure that they're dangerous or public health hazards. We don't really know, but we err on the side of safety in that case. That's all I got to say about e-cigs. All right. Any questions on smoking?
A pregnancy one. Is